Hi friends, last time I talked about diabetes and the eye. You remember how I talked about the various problems created by diabetes and how it manifests with loss of vision. Today I will be talking about diabetic retinopathy management. I am Dr. Gopal s.Pillai, Head of Ophthalmology at Amrita Institute of Medical Sciences, Kochi. Please subscribe to my channel and press the bell icon for getting all the videos immediately. So as I told you before, diabetes is a major problem in India. You should understand that more than 45 years of population, if we look into, lots and lots of people are diabetics and many of them are hypertensives and a lot of them have complications secondary to it like diabetic retinopathy or kidney disease or heart attack or stroke or neuropathies. Managing retinopathy is a very important thing because of multiple counts. Number one, it is completely asymptomatic in the beginning, which means that the patient or the person who has diabetes has no idea when the diabetes is striking his eye and the time bomb is ticking inside his eye. Only in the very late stages, when vision starts dropping significantly, will he realize that he has a significant diabetic retinopathy. Number two, many of the patients who present with diabetic retinopathy has a small window of opportunity. In 6 months or 1 year, if you treat the patient quite well, these patients will have good vision throughout their lives. But if we are not able to provide that treatment, or if the patient is not able to access that treatment in the 6 months to the 1 year period, probably he will go permanently blind. Number three, I talked about permanent blindness. Yes, in diabetic retinopathy, once the vision drops down, in many people, it is permanent blindness. So because of these three counts, we require to treat diabetic retinopathy quite early. So let us look at how we pick up diabetic retinopathy. We are a population of 1.4 billion people in India. And if you look at the number of diabetics who require screening on a yearly basis, it's mind-boggling. So screening is an important thing in a diabetic who do not have any symptoms also. At least yearly once, he should get his eyes dilated and examined by a specialist to look at whether he has diabetic retinopathy or not. Once he has diabetic retinopathy or diabetic retinopathy like problems inside the retina, the specialist would be able to tell you whether it is actually diabetic retinopathy. That is a diagnosis of the condition. Once you screen, once you diagnose, the next thing is grading of diabetic retinopathy. So grading is done again by a specialist using techniques like fluorescent angiography or optical coherence tomography. These are some of the tests and scans that you do to find out diabetic retinopathy. And you would grade the diabetic retinopathy broadly into non-proliferative and proliferative diabetic retinopathy. Proliferative being the worser of the lot. Non-proliferative diabetic retinopathy further subdivided into mild, moderate, severe and very severe diabetic retinopathies based on morphological examinations. Proliferative diabetic retinopathy, on the other hand, is a stage where you will have bleeding inside the eye or the retina may get torn and cause a retinal detachment, or suddenly pressure may go up and damage the eye, causing neovascular glaucoma. These are conditions which are completely blinding and permanently blinding. So proliferative diabetic retinopathy, people are said to have vision threatening diabetic retinopathy. And it is important in the screening to pick up vision threatening diabetic retinopathy in proliferative diabetic retinopathy, as well as edema at the center of the macula called macular edema. If there is edema right in the center of the retina, the vision gets blurred, and most probably these patients' ability to read and write and to identify a person will be gone. Whereas in proliferative diabetic retinopathy, when you have bleeding or traction retinal detachment, as I said, the people will lose the ability to actually see. They become blind. They will be seeing a blur or a black in front of their eyes. Now, how do you treat diabetic retinopathy? In the early stages, like for example, mild diabetic retinopathy or moderate diabetic retinopathy, you only require maybe yearly follow-ups, or maybe in moderate diabetic retinopathy, maybe 6 monthly follow-ups to see if the diabetic retinopathy is progressing. But on the background, you have to have good metabolic control, like control of diabetes. Your hemoglobin A1C levels, which is a 3-month sugar levels, should be near about 7. Your cholesterol, your triglycerides, you can keep your lipids lower. Your protective lipid, the HDL, can be more than 40. So these are some of the things which can help prevent the progression of diabetic retinopathy. If somebody has a kidney disease, that needs to be managed well, blood pressure management, cardiac management, all these will add in protecting the eye from progressing further in diabetic retinopathy. So I told you metabolic control is a very, very important parameter. Next, we have lasers, and I will come to that in a short while, when we require laser and when we require to do injections. Number 3 is intravitreal injections, which are injections of anti-VEGF agents which we inject right into the center of the eye. It is done under topical anesthesia and it is completely painless. And many patients with diabetic retinopathy will require repeated injections to keep the vision better and even prevent loss of vision. So let us take 2 major vision threatening diabetic retinopathies and see how we manage them. Number 1 is diabetic macular edema, in which the central of the retina has edema. And when the central part of the retina has edema, we require to evaluate how much is the thickness based on an OCT, an optical coherence tomography. It's a scan which is run to find out how much is the thickness. You give an intravitreal injection to reduce the edema. Each injection will reduce the edema by about 10%, and once it reaches about 300 microns, which is about normal thickness of the retina, we will stop injections. So an important question that a lot of patients ask me is, should I do injection now, doctor, or should I wait for an injection to be done? So if there is edema more than 350 microns, and if there is decrease of vision in macular edema, that's a definite indication for an injection. And earlier you start, the better, because a lot of studies have shown that if you wait for 1 year or longer, your final vision that you will get after treatment would be lesser than if you start treating early. The next question that people ask is, doctor, how many injections? So in a lot of studies across the world, it has been shown that in the first year, you require approximately 8 to 9 injections to keep the edema the lowest and to improve the vision the highest. By the second year, if your sugars and blood pressures are very well controlled, the number of injections will drop down to 4, And by the third year, it will further drop down to 2. And by the fourth and the fifth year, you'll be able to stop the injections. So, initial year, the number of injections will be higher, but provided the blood sugars, blood pressures are all controlled, the number of injections keep on reducing year by year, and the diabetic retinopathy can be controlled like that. However, in the real world, we start with 2 or 3 injections and then see how the response is, and based on the response, we would either treat and extend, which means we would extend the interval between the injections, or if the edema is completely reduced, we will just ask the patient to follow up and see the patient again maybe a monthly basis and look for edema, and if there is edema, we may consider treating the patient. These two philosophies can be there. Either you can extend the treatment slowly, or you can stop the treatment, and as the edema recurs, we can inject. Treat and extend is a slightly better in terms of final visual acuity. If there is proliferative diabetic retinopathy, I told you that proliferative diabetic retinopathy is a condition where there could be bleed inside the eye, traction retinal detachment. Initial proliferative diabetic retinopathy, when there are multiple neovascularizations inside the eye, is best treated with an anti-VEGF injection followed by good tight laser photocoagulation. Laser is a methodology by which you have laser spots on the retina and slowly it will dry up all the neovascularizations. Unlike injections whose effect lasts for about a month or 2, the laser's effect is often permanent, and so that would reduce the chances of progression of diabetic retinopathy if laser is performed at the correct time. The next question that people ask is, Doctor, I had 3 injections. I do not have a significant improvement. Now what I should do? So, usually when we start treatment, there are multiple different injections in the available in the market. So if you start treatment with one particular brand of injection, generally you may move to another brand or another type of injection. Like for example, there are a lot of anti-VEGF injections like bevacizumab, ranibizumab, aflibercept, brolucizumab, faricimab, etc. And there is another group of treatment called ozurdex, which is a steroid injection. So if one anti-VEGF failed to have effect, we can move up the ladder to another type of anti-VEGF, or you can move to another class of drugs like ozurdex, which is steroid injection inside the eye. Generally, these injections are very safe, and in 1 in 10,000 people, one may have an infection inside the eye or some other problems. Some of the common problems may be a small bleed at the site of injection, maybe a redness, something like that. They are very, very minor problems. And usually we will avoid injections when the patient had a stroke or a heart attack within the last 3 months, or if there is any source of infection anywhere in the body. Beyond salvageable diabetic retinopathy, beyond injections, one may require surgery. So when a lot of bleed is there within the eye and it is not going away within a 1 month or 2, then we may consider surgery to remove it. Or if there is a traction retinal detachment, we may have to do a vitrectomy surgery to reattach the retina. With good treatment, definitely more than 90 to 95% of diabetic retinopathy patients can maintain very good visual acuity throughout their lives. Thank you very much. Don't forget to subscribe to the channel.